afternoon. So speaking about an interesting topic, a new product, a new peptide, gallium FAPI PET-CT in GI tumors. As a part of this talk, I think this is the last talk in the Theranostics series. But it's very apt to put it in the last because I think this is going to be the major trendsetter and it's going to change the direction of the way we treat or we image many of the solid tumors. So the FAPI, the fibroblast activation protein, it's highly expressed in the stroma of several tumor entities. Breast, colon, pancreatic carcinoma show strong desmoplastic reaction. 90% of the gross tumor mass can consist of stromal and not tumor cells. Cancer-associated fibroblasts differ from normal fibroblasts by providing FAP as a target with relatively higher tumor-specific expression. FAPI has already been used as some of the cancer treatment. This diagram to show an example of, say, a gallium DOTA FAPI. What could be the mechanism of its action? The cancer tissue and its several of its environmental, the local tumor environmental participants. They all create the CAF or the cancer-associated fibrosis. And what I want to say in this scan is that the FAP is specific for fibrosis, arthritis, atherosclerosis, autoimmune disease, metabolic diseases, and cancer. So this is one pathway which is there in several of these tumors. And this is a diagram to show the interaction between endothelial cells, normal fibroblasts, the other connective tissues like adipocytes, the marrow cells, the progenitor cells, and the tumor cells, and interact, and they create this. This interaction creates these cancer-associated fibroblasts. So this is something like a person who is always present in most of these cancers. And gallium FAPI PET-CT, it's a molecule which is attached to gallium-68. It is complementary to tumor entities showing poor FDG uptake, that's because of poor GLUT expression. Example, hepatocellular carcinoma or pancreatic cancer. Also, high FAPI uptake is seen in esophageal cancer, non-small cell lung cancer, head neck cancer, and colonic cancer. FAP is overexpressed in cancer-associated fibroblasts and has limited expression in normal cell, and that is a big game changer. So, in PET-CT, the current standard of care, which is the FDG PET, the 18F FDG PET, fluorine 18 labeled deoxyglucose, has high uptake in brain, heart, liver, spleen, and gut, and it has done extremely well in most cancer situations, although it has limitations in gastric malignancies, peritoneal metastasis, mucinous adenocarcinomas, and also in clear cell carcinomas. Limitations, therefore, exist in some GI, GU, GY malignancies. However, what is important to know is that they have done very well in the last 20 years, and therefore, they have been the basis of treatment, follow-up, treatment modification, and excellent staging tool, which has led to so much of stage migration in many situations. But when we take the new agent, the gallium FAPI PET, it has very limited uptake in brain, heart, spleen, liver, gut. So there is a modified biodistribution compared to that of FDG PET, and that gives excellent contrast, excellent inbuilt contrast. FAP is overexpressed in several abdominal and pelvic malignancies. It performs slightly better than FDG across all solid tumors, and therefore it has new application of characterization, staging, monitoring treatment. A very early and landmark paper published way back in 2018 on the comparison of FDG PET and gallium FAPI. Well, we can say that FAPI performs as good as FDG PET in several tumors, and in several tumors it performs superior to FDG PET. And if we, for understanding that, this bar diagram will be very useful, because this is a way by which we have represented the SUV uptake in so something like the red line shows the normal blood pool activity. And you will find almost all the tumors. We are starting from renal cell carcinoma to the cancer of unknown primary. And you will find that they all show significantly raised SUV in almost most of the tumors, and some of the tumors show almost 3 times more uptake compared to that equivalent of FDG, and therefore they are a straight winner. So since the uptake is more and the biodistribution is such that the normal biodistribution is very much restricted, and there is not much of normal uptake in large organs like brain or heart, I think straight away we have a winner, because it will automatically bring up the diagnostic supremacy. And this is an example to show. I want you to concentrate on difficult tumors like ovarian cancer, pancreatic cancer, medullary thyroid cancer. So where earlier the performance of FDG PET was not so great. Also, the radiation burden to this patient is going to be almost 50% of that of F18 FDG PET. That's largely because we will be using gallium-68. However, that is changing, that now we have F18 labeled FAPI agents that's available in the last few months, and this is going to give the same opportunity to all the centers, whether they are close to a cyclotron or they are very far from a cyclotron, because we are going to have F18 labeled FAPI agents, and that's going to provide excellent distribution opportunity like that of FDG. So coming to the relatively a smaller part of the discussion, gallium FAPI PET-CT in GI malignancies, I have just taken a few examples from our own experience. So this is a case of a signet cell carcinoma of the stomach, and what we are seeing here on the left side is the FDG PET. There is normal uptake in the brain, but the uptake in the primary tumor is very, very less. In fact, we are able to appreciate the CT findings rather than actually the uptake. In fact, the uptake is as much as the background and hardly any. But when you look at the FAPI PET, the uptake is significantly high, and therefore we are able to see the uptake in the primary disease and also in the locoregional disease. So that makes it a very, very significant advantage. We are able to see metastatic peritoneal deposits, although that has not shown in this particular case FAPI uptake. Now this is a case of mucinous adenocarcinoma, and here again we have very, very little uptake on the FDG PET, and the supraclavicular nodes also show very little uptake. But however, we will find excellent uptake in the case of the FAP, and the FAPI is showing very good uptake, and the supraclavicular nodes also are showing very good uptake. So this is a signet ring cell carcinoma of stomach. So all these groups, signet cell, mucinous adenocarcinoma, these had a very poor expression of GLUT in that. That's why FDG was not being used for them. In fact, many authors were of the opinion that we should be actually looking at thybidine kinase, and we should be using FLT rather than actually using FDG. And in fact, many histopathologists also believe in giving KX67 score for these. But all these have now changed, because now we have FAP, and FAPI will do very well, and it will surely replace FDG in this. In fact, FAPI PET has now given an opportunity to look at many of these tumors, both at tumor at staging and also at restaging. So this is another case of a signet ring cell carcinoma of the stomach, and FAPI uptake in soft tissue mass proximal to metastatic left supraclavicular region is that we just now saw. And this is a case of a carcinoma of the rectum, and normally one of the important problems in the post-treatment scenario, we have a fibrotic tissue, we do not know whether it is viable or not, and this is a case where equivocal uptake on the PET, but we are able to see excellent uptake on FAPI. The adenorectal soft tissue mass, and this is a case of a carcinoma head of pancreas. In the CACT, we find that there is a pancreatic head mass, suspicious liver lesions, and FAPI PET-CT shows FAPI uptake in the pancreatic mass. So if you look at the FAPI PET-CT, we are able to appreciate it very well both the liver lesion and also the primary uptake. And therefore, this gives us an opportunity to do an assessment of the pancreas in one go. And this is a case of a periampullary CA post-surgery, where there is a recurrence in the liver lesion, in which underwent actually treated earlier with an RFA. And there were also some new lesions coming up at the aortic cavity in the surgical staples, and also segment 7 lesion, which is the post-ablation region. And what we are able to see that there is an excellent uptake on the soft tissue lesion around the surgical staples. So it solves the problem, and it gives you a total different perspective compared to that of the FDG PET. In the case of hepatocellular carcinoma and hepatic nodules, while FDG PET was really used desperately, but however it was never accepted because the uptake of FDG was inversely proportional to the differentiation. So a well differentiated tumor would hardly show any hepatic uptake in the HCC. And except in a few difficult situations or rare, that also by few surgical groups who would use FDG PET to look at the uptake in the HCC prior to major surgery like a liver transplant, to understand the biology, where they gave it FDG uptake was considered as a very important part of the bad biology or the bad prognostic indicator in that situation. But now this is a paper which has looked at the liver nodules and this HCC, and which shows that the uptake is directly proportional, or uptake is directly proportional to that of the unlike the FDG, there is no variability in the HCC with respect to that of the uptake of the FAPI. So this as a theranostic molecule will now give us a lot of opportunities to treat this patient during various phases of this disease. And the FAPI in a case of a peritoneal metastasis and bone metastasis in another such case. Now an example, that was a small spectrum of GAE tumors we saw, and this is an example of a carcinoma right lung with brain metastasis. And lung is one region, lung, especially the non-small cell lung cancer, where the GLUT expression is excellent, and therefore FDG PET CT has been playing a very important role in the assessment of lung lesions, CA lung. But how does this change with FAPI PET? So this is an example where I have taken a patient who had brain metastasis, and so this is a normal FDG PET, and there is significant brain uptake, and this is the primary uptake in the primary, and you see here that the brain lesion shows hardly any FDG uptake, and therefore becomes a false negative. But on the FAPI, the uptake in the primary disease is significantly high, and the uptake was also seen in the brain lesion, and it is pretty good. And because of the absence of uptake in the normal parenchyma, the contrast is excellent. So it is already a far superior diagnostic tracer compared to that of FDG. So if you take when we take theranostic as a concept, we diagnose, we are able to diagnose on an hybrid image. We are using several molecular agents, which could be biochemical agents, or it could be peptides, or it could be amines, and they are labeled with positron emitting isotopes like gallium-68 or F18, and therefore FAPI is an excellent diagnostic tool in a hybrid imaging mode. And this seems to be better than FDG in almost all the tumors, and in all the tumors, especially the solid tumors. So now, having diagnosed them, earlier the question which used to be asked in a scan reading room is, oh, we are seeing so much of uptake. Sometimes we used to use the word Dalmatian scan, that scan looks like a Dalmatian. But why can't we treat it immediately? And we say, no, FDG can be diagnosed, we cannot treat. And now we have the concept of theranostic, and we have a theranostic pair, and the pair is the same FAPI is now labeled with an a different type of isotope, and that isotope commonly is the lutetium isotope. So the therapeutic counterpart is lutetium DOTA-FAPI, and this lutetium DOTA-FAPI will go exactly to the same place where the gallium FAPI went, and because it is carrying an isotope uh, which has beta rays or alpha rays, and therefore it can give significant amount of radiation to those regions, and the what you can call as focal, regional or cellular level radiation will be a very good therapeutic modality. Now, talking about this DOTA-FAPI, it was seen that while we talk of gallium FAPI, here the retention of the product is not very important, because once we inject, within 60 minutes we anyway finish off the imaging, so the retention is not so important. But in therapy, we expect the molecule to stay in that region for a reasonable long time. Ideally, if you take a good agent which is getting internalized, like for example, iodine 131 is a very good theranostic tool. You can use iodine 131 in small quantities. You can use it for diagnosis. And when you use it in large quantities, that is therapeutic. But what happens in iodine 131 is when it's taken up by the thyroid follicular cells, it gets internalized, it gets organified, and therefore once it gets internalized, it stays there, and therefore the small amount of radiation but continuous over a long period of time gives huge amount of radiation, and therefore it's a very superior way of treatment. So retention within the tumor is an important thing, and we find at the present that the DOTA-FAPI retention is not very good. However, actually the whole story of FAPI in the clinical world is just the last 3-4 years, from 2018. And now we have a dimer. That means we have actually two molecules or two FAPI components as one single entity. And that has significantly improved the retention. And this landmark work has been done by a group from AIIMS, my colleague Dr. Bal. He has made a very big contribution. And this is, for example, a case of CA breast. Now you see bulk of the disease is in the marrow and in the bone, and this is picked up on the gallium DOTA-FAPI. It's a dimer FAPI. And the same, when it is being converted into a lutetium DOTA-FAPI, now what they are seeing is that the retention is not very good, but still there is good amount of retention till 24 hours, which will give a reasonable amount of radiation. And but for example, this is a case of a thyroid cancer where the patient has multiple bone metastasis and marrow metastasis, and also there are some bone lesions which also show FDG, which means there are more differentiated and non-differentiated elements, some showing root expression, most of it showing sodium iodide symptomatic expression. But when this patient was scanned with DOTA-FAPI, and almost all the lesions show excellent DOTA-FAPI uptake. And when this patient was treated with the FAPI dimer isotope labeled with lutetium, you find here the retention is pretty long as 168 hours. And this is an excellent proof of the pudding to say that, this is something which is going to be there, because this will give a large amount of radiation. So now we have the proof also, and now we possibly have a solution, which is the dimer FAPI, which is going to be available as the therapeutic option for FAPI. So now we have on the therapeutic side, we have lutetium, yttrium-90, actinium-225. Now lutetium has got a good penetration, but it has what we call a soft gamma, soft beta. So for example, it's very likely to prevent marrow damage, and also it's very likely to prevent the kidney damage, because it will not get penetrated much. But yttrium-90 has got a very long penetration compared to that of lutetium, but its half-life is very less. So it irradiates, and that's why yttrium-90 has been used for tire agency. But actinium-225, it's an exclusive alpha emitter, and alpha emitters are known to be excellent. They give a lot of radiation, but since it is only for a very small distance, they spare, and this way when you have a patient who has a lot of bone cortical disease, you can use actinium-225, as the marrow will be completely spared. I don't think there is any other treatment which can spare the marrow as much as 225 actinium can. And also we have rhenium and samarium. These agents have relatively longer half-life. The Radium has a shorter half-life and Samarium has a longer half-life. And these also are agents which have been now shown to be labeled with FAPI. So there are half a dozen of these isotopes, and we can make the right choice depending on the situation, and we can treat the patient based on what we see as the uptake on the diagnostic scan. So a diagnostic FAPI and a therapeutic FAPI put together is going to open lots and lots of opportunities for all of us. So in Theranostics, FAPI is a molecule which is going to, which is the most exciting molecule at the present moment, as a one-stop solution possibly for most of the tumors, especially the solid tumors. And it is going to be very, very interesting as the medical oncologist and nuclear physician are going to partner, and we are possibly going to sit together and identify what would the best protocols to have the least amount of toxicity and the best outcome in most solid tumors. With this, I would like to conclude my talk, and I thank sincerely the organizers of this conference to give an opportunity to talk about this wonderful molecule. Thank you very much.
There are no questions as such for this talk. Just one question from my side. Since you have been using FAPI extensively, what is your experience as far as GI malignancies are concerned? And particularly from the theranostic point of view, if at all we have to treat, then do we have to do both the scans, FDG as well as FAPI, or one scan would be enough if we have to go ahead with therapy?
Well, we have a small experience. I mean, I wouldn't say that experience is very large. Maybe we would have done a few dozen scans. But there is a publication which has looked at least the gastric tumors and also has looked at hepatocellular carcinomas. A lot of publications are coming from China. So as it stands, there is enough evidence to say that you can actually conveniently not do FDG and do FAPI straight away. You will get better diagnostic yield. And so far, if you look at it, there are some groups in the world who were using the existing FAPI, but they were labeling with actinium-225. You know, actinium-225 being alpha emitter, because the retention, as I told you, was not even more than 24 to 36 hours. They were managing with alpha. But now, with what the type of work which is published by Dr. Bal and a few of the international collaborators, the dimer approach seems to be very promising, and that surely seems to be increasing the retention fraction. If that is so, I think it will make a huge impact. And incidentally, if you see, gallium PSMA also has been used in hepatocellular carcinomas. People have shown diagnostic accuracy and a reasonable amount of retention, but however, there has been no publication of any dosimetry data of people using lutetium or actinium PSMA in hepatocellular carcinoma. So the theranostic approach in GI tumors across is very much restricted, other than the ones which we have on neuroendocrine tumors. So that's a huge opportunity available for us, and I think we should grab it, because anyway these patients do not have much option otherwise also. So I think the respective IECs of the centers should encourage this type of work, and I hope we are also lucky to get some good international collaborators who can share these dimers, because these are all very, very, I would say, precious products, because they have huge potential, and obviously they would not like to share with so many groups. But I think that is one option which is available, and I'm sure that will be entering clinical practice. So at the present moment, doctor, I would like to recommend that from a purely diagnostic point of view, I think for GI we should quietly shift to FAPI, and that is rather than doing FDG. That is my first recommendation. And second recommendation is, very soon, I am very confident within the next, maybe within another 12 months, we will have an excellent product which will be a theranostic product, that is the therapy equivalent. And there we should start identifying good groups on whom the standard of care has been already completed. We should take those patients and we should offer them the theranostic approach with FAPI. That's my view.
Thank you very much, sir.